Today we are talking gout. Now, gout has some features, but let's define what gout is first. Gout is an inflammatory arthritis from monosodium urate crystals due to excess serum uric acid. Okay, let's break that down. So number one, it's an inflammatory condition, right? So there's different types of arthritis that can be categorized as non-inflammatory or inflammatory. OA or osteoarthritis is the classic non-inflammatory one. There's other ones that can cause rheumatologic symptoms like fibromyalgia and others, acute injuries, whatnot. But this is an inflammatory one. So we see gout, rheumatoid arthritis, other spondyloarthropathies, including psoriatic arthritis, reactive arthritis, ankylosing spondylitis. So this falls in that category. Now it has those features of inflammation. So those 5 cardinal ones that we see: the pain, the heat, the swelling, the redness or loss of function, or if you like the Latin, the dolor, the calor, the tumor, the rubor, and the functionalia. Okay, it's an arthritis, right? So it affects joints, classically the big toe joint, the metal tarsophalangeal joint. Often this is known as podagra. And if you look at the x-ray here, you can see that haziness, which is those crystals, those monosodium urate crystals that are there. And if it gets severe enough over time, you get these erosions actually from those crystals. But usually if it's a first-time episode, it's probably unlikely to have that. So crystals, the classic diagnostic criteria is these negatively birefringent crystals under polarized light. What in the world does that mean? So birefringent just means it refracts different colors depending on the angle of the light. So here we see it shines blue one direction and red or yellow in a different direction. And so and they call it positive or negative depending on the angle. So probably more than you wanted to know, but that's why it's negatively birefringent crystals if you analyze the synovial fluid from which you pull out the affected joint. Now let's go back through that again a second time with more detail. Now, inflammatory, of course, if you do the blood work, you'll see a high CRP or ESR, but these markers are not specific enough to diagnose gout, so they would not be that helpful, but they can be drawn. Of course, we said it's arthritis, which means it affects the joints, but guess what? It can also affect soft tissues, gout. So this is a classic olecranon bursitis affecting the bursa of the elbow. And you can also have gouty cellulitis, which can be misdiagnosed as a cellulitis that's not responding to antibiotics, or paniculitis, which includes inflammation, which is inflammation of the fat tissue. Now, this is due to excess serum uric acid, right, as gout. But what does that mean? Well, let's review a little bit of where uric acid comes from, or urates. So we see purine catabolism, meaning breakdown of the purines, which is part of our nucleic acids, our DNA. And so 2/3 of our uric acid is actually from our nucleic acid turnover. Only 1/3 is from diet. So purines go to xanthine, xanthine goes to uric acid. In most animals, or most mammals, uric acid can be converted to allantoin, which is a very soluble form of a compound, versus uric acid is not. So mammals lack this enzyme here, the urate oxidase, also known as uricase. Okay, so then how do we accumulate serum uric acid? Well, by logistics, you either underexcrete, overproduce, or just from excess breakdown. So underexcretion of uric acid is the most common cause of having high uric acid levels. People are just underexcreters. And of course, if you have CKD, you have kidney impairment, you're not going to excrete very well. Now, if you're an overproducer, this is oftentimes due to genetics. One may have a defect in purine metabolism, so there's just excess uric acid being produced. Again, why would you have excess purine catabolism or breakdown? Well, you may have a myeloproliferative or a cancer like leukemia, lymphoma, where there's lots of breakdowns of cells. And of course, uric acid is inside those cells, so those being broken down releases a lot of uric acid, and that's a problem. And sometimes during chemotherapy, you can get tumor lysis, right? You're trying to kill destroy the tumors, and there's again lots of lysing of cells, and that causes excess levels of uric acid. Okay, some more things here to know is that if is high in the serum, past a certain saturation point, that's when crystals form. So on average, that's about 6.8 milligrams per deciliters for a certain body temperature and pH. That can change. But one very, very important thing to know is high serum uric acid levels does not equal gout. This is to be emphasized because you draw a normal serum uric acid level, that doesn't mean that person does not have gout, or some people will have really high serum uric acid levels and never develop gout. So uric acid levels should not be the sole way of diagnosing gout. Okay, gout affects men more than women on a 3-to-1 scale. Some would say as high as 10-to-1, but regardless, men are affected more than women. The first attack for men is usually in their 20s and 30s. Women actually don't get it much until they get postmenopausal. Why? Well, it's because estrogen actually promotes urate excretion, so they can excrete more urate and not build it up like men do. Now, men and women, of course, can present in similar ways, but there's slight differences at times. Men, again, typically get the big toe. They can get gouty arthritis in the knee, and if given severe enough, it can actually, believe it or not, affect the spine. So that's one thing to consider. And you see these in the x-rays, these, again, funny looking punched out lesions in the spine, which is horrible. And that's from the erosions from the crystals. Women, again, can get it in toe too, but one distinguishing feature is they can get it in the fingers as well. They can present in the fingers besides the knee and the big toe. Okay. What's the best diagnosis? We already established it's not from uric acid levels in the bloodstream. So aspiration of the affected joint. But in reality, most people would not do that. It's just a little bit invasive, not a little, it's very invasive. It's actually more to rule out septic arthritis, right? Like if someone has a knee like this and at the clinic presents like this, we often think, uh-oh, is this a septic arthritis, maybe from gonococcal or from something else? So you have to aspirate it more for ruling out the septic arthritis, and you may send it out and then say, oh, look, there's these negatively birefringent crystals. It's gout. There it is. Leukocytes can be high from inflammation, 2,000 to 10,000. And again, remember, high serum uric acid levels does not equal gout. Okay, stages and treatment. Acute, intercritical, chronic. Acute flares are, of course, when the pain gets really bad. Intercritical means between flares. Oftentimes, you can still have some low-grade inflammation, and if it's not controlled long enough, it becomes chronic. So people get chronic gouty arthritis, which is not good. The acute flares, how do you treat it? Typically with colchicine, 1.2 milligrams one time, and then half that dose an hour later. Use NSAIDs like indomethacin, and then oftentimes steroids, which can be intramuscular, intraarticular, or by mouth. Intraarticular is oftentimes preferred if it's just one joint, but most realistically, most people will probably do the PO route by mouth. Now, if this flare is lasting forever, you've done so many things, you've done the NSAIDs and the steroids, but it's not refractory, then you might move on to a bigger gun like an interleukin-1 beta inhibitor, which is like anakinra or canakinumab. Okay, so chronic. Now, there's meds especially to be on long-term if you have one of these three features. Tophi, which are the buildup oftentimes you can see on elbows and knees and certain other joints. You can have flares more than twice a year, or 3, you see the changes noted on imaging like we showed earlier. Okay, so to treat it, we use urate lowering agents. And again, the two primary ways is it's lowering the urate production or just increasing the urate excretion, right? Basically addressing the two primary ways that we talked about earlier of why someone would have high uric acid levels or urate levels. One thing to know about all this is these urate lowering therapies are not to be used by themselves in acute flares. So people oftentimes with chronic gouty arthritis will have acute on chronic, and you should not be using allopurinol to try to bring that down, or febuxostat to bring that down, because you may actually cause the flare to last longer. So you can use it once the NSAIDs or the steroids have kicked in a little bit, and that could be fine, but never by themselves. Okay, so real quick here. So sorry for that. The chronic ways of managing it. So we have allopurinol, which works here on the xanthine oxidase, which, as you see, xanthine turns into uric acid. So you start with 100 milligrams a day, then you taper up until uric acid levels are under 6 milligrams per deciliter. One of the downsides of allopurinol is some people get this drug-induced hypersensitivity syndrome, especially in Southeast Asians like Han Chinese or Thai or Koreans or certain Africans. So you may want to check for HLA-B 5801 first. Now, if allopurinol doesn't work, or again is contraindicated because of this hypersensitivity syndrome, then you may use something called febuxostat, also known as Uloric brand name. It's more effective or just as effective as allopurinol, but there's a warning with those with cardiovascular disease to be careful. May not be a wise idea to use. Okay, how do we increase excretion? We can use a medication called probenecid, not as common anymore. Especially you can't use it if your kidney function is impaired. So if you have EGFR less than 50, you got to be careful. But some rheumatologists, some primary care may still use this, oftentimes in combination with one of these two agents. So you kind of hit both things. You decrease the production and you increase the excretion. Last way is an IV form. It's called IV pegloticase Krystexxa. What that is actually it impairs uric acid from turning, or sorry, it actually helps uric acid turn into allantoin. Remember how earlier I said humans don't have this uricase enzyme? Well, guess what? This is what the medication is. And it is very effective when it does work. But the downside of it is it's about a third to half of the patients actually develop antibodies against this medication, and so it becomes ineffective quite quickly, and there becomes an increased risk of infusion. So for those that does work, great. Then they can get an IV infusion every 2 weeks, and you monitor the levels of the uric acid. If it doesn't come down to less than 6, after 2 infusions, it's usually stopped. And oftentimes this is so effective, it brings the uric down to like really low levels, can be close to 0. Anyways, that is the quick summary of gout management.